We are very excited to welcome today Dr. Nir Shimony, who is a pediatric neurosurgeon with you operate at several facilities, including Bonheur Children's Hospital, and you do have a special expertise in epilepsy and brain tumors. So welcome, Dr. Shimony. Thank you for joining us.
Thank you for having me, and thank you for this opportunity to talk about something that we really try to advocate for, both facilities, St. Jude and Bonheur.
Wonderful.
Oh, sorry. Yeah.
Yep.
So let me just move this. Yeah. Okay. So the idea is that I would like to talk to you today and all the parents is about this combination. And I started my presentation with when the lightning strikes twice. Having a kid with both brain tumor and epilepsy. And I will, along my presentation today on our discussion, we'll say that several times. We're not talking in particular about seizures because patients can have a brain tumor and a seizure that they are presenting with. And this is completely different from having an epilepsy and brain tumors, which is more complex, and it's not a single seizure or something that is very easily treated. I'll try to take you through several of those elements, including patients that are presenting with a seizure and brain tumor, those that have a tumor, got treatment, and eventually after 2-3 years, all of a sudden start to have epilepsy, even a very hard to treat epilepsy. We will talk about treatment options, including surgical resection, including laser, but we're also going to talk about some new features such as neurostimulation and neuromodulation, for that we cannot really resect or do something that is more definitive for the brain tumor and the epilepsy itself.
Great. That's a lot to cover today. Thank you.
Thank you. So seizure is a common complication of brain tumors. We know that it can come in different stages of the disease. I said that before, and I'll say that several times today. We will define epilepsy from an actual seizure, and we will define intractable epilepsy from, I would say, controlled epilepsy. And in very simple terms, controlled epilepsy is when you do have epilepsy, but with the treatment, you don't have seizures. You're okay. You still have an active disease, but your life or your quality of life are currently okay. And the word currently is important because that can change. Yeah. Seizures are different. You can have a seizure. We know there are patients or kids that have seizures out of having high fever, patients that have seizures out of having a viral disease, and patients can have a seizure out of having now a brain tumor, but that does not make it epilepsy. Patients that have brain tumors and all of a sudden have a breakthrough seizure, have all of a sudden a start of epilepsy after a while, those are a lot of times signs for some bad features, such as progression or recurrence of the tumor, such as a delayed brain damage, for example, after radiation therapy, or some interaction with their oncological treatment that now lower the levels of their medicine. And we see that quite a bit. A lot of times, I would say that the notion, even among neurosurgeon and oncologist, is take the tumor away. That will solve both problems, and this is true in a lot of cases. That's a right rule of thumb in general. Yet we have a responsibility to understand that it's not going to happen in a lot of cases, and you'll see me quoting numbers such as 25%, even 40%. That will have delayed appearance of epilepsy, sometimes a very hard to treat epilepsy, after the tumor is gone, but they are under follow-up.
Oh, wow. I did not know that you could have that later. And when we're talking about tumors here, are you talking about both benign and malignant tumors or both?
So very good distinction, and we'll talk about both. And very interestingly, we'll see that although maybe the logic will say that, the tumor, if it's very aggressive, you're going to have a much more worse epilepsy. It's actually the opposite.
Oh,
Those
really?
that are more low-grade tumors, or it's hard to say benign in the brain, but let's say more low-grade, tends to actually lead the patient into more complex epilepsy. And this is about their interaction with their brain parenchyma environment, rather than the very aggressive tumors that, yes, they are very hard to treat from oncological perspective, and a lot of time have very bad prognosis, but a lot of times are not really related to hard to treat epilepsy.
And brain parenchyma is the term for, I like to say, just the whole brain, all of the stuff that we think of that makes up the brain, the tissue, right?
Correct. And now, and maybe it will be a good idea to define now that when we say brain cortex, for example, is the shell of the brain, which a lot of times is where the seizures are being generated. But the parenchyma is basically not just the white matter, but all the inner part of the brain. Basically, you can call it the flesh of the brain.
Got
Uh,
it.
and we will, we'll jump between these two terms, but in general, we're talking about the brain itself.
Great. Thank you.
So when we talk about seizures as a manifestation for brain tumors, it's quite common. Some studies talk about like a quarter of the children, 25% of the children will have some degree of seizures as well in their presentation with the brain tumor. Some even say more than that. Location matters. Some areas of the brain are more, I would say, susceptible to create seizures. And again, we're not talking about epilepsy. We're talking about seizures in general. For example, the very classic one is temporal lobe, which resides here, I would say, in the level of our ear on both sides. This is a very epileptogenic lobe. A lot of times when we have seizures there, when I'm saying epileptogenic, it means that more prone to have seizures. When we have a tumor there, a lot of time that will come with seizures. The
Okay.
frontal lobe, which sits here, also have this kind of tendency, and the rest can have that, but less. So location does matters in terms of the likelihood to have seizures. Now, I'm coming from Memphis, so I have to have some Elvis on my presentation eventually. Not every seizure is epilepsy, bottom line, and not every epilepsy is intractable epilepsy, or I would say in more simple term, drug-resistant epilepsy. There are definitions, and we don't like those definitions because some of them are a little bit obsolete or old, but it helps to get the idea. And the idea is that if you treat your patient with at least 2 different medications and you do it for about a year and it's still not enough, then you can define it in general as intractable epilepsy. Now, don't quote me by the exact number, the exact time, because it's not exactly that, but it gives the idea. So having a seizure immediately after surgery doesn't make it epilepsy. That's quite common, actually. Just from, and I a lot of time I tell the families, from us poking around or taking the tumor away, that can cause seizures for anyone that his brain is exposed to the air. This by itself can cause seizures. It doesn't make it epilepsy. We will focus more here about the idea of having an actual epilepsy, or more likely intractable epilepsy with the brain tumors. That's what makes it more complex to treat. And those are the families that I really want to address in terms of there are solutions. There are solutions for others as well, but I want those specific families that's been told there's nothing to do. We took the tumor away, now live with the epilepsy, to say there are other options.
There are choices that they can make, or things that they can start to consider. So today we're not going to talk about the kids who after surgery have a couple of seizures. I think in some areas, or some literature calls it acute postoperative seizures. And we see these in other resections or hemispheric procedures, which a lot of our families have kids who have those. You're talking about the kids that develop epilepsy, a lot of seizures, and then those who are out here, which is medication is not helping their seizures, and they now have what's known as drug-resistant epilepsy.
Correct.
Okay.
And I will try to give a little bit of a glimpse about the first group as well, but that's not going to be our focus.
Okay.
Now, I'll fly a little bit fast through some of the tumors perspective. It is important, but that's not our focus today. If parents ask themselves about, how common is to have a kid with a brain tumor, or we call it CNS, which is central nervous system. It's brain and spinal cord. It's actually, unfortunately, very common in terms of in the world of oncology. It's I'm saying that not in a cynical way, in a bad way. It's in a competition with leukemia always to be who takes the lead in terms of the most affecting cancer on pediatric population. And currently it's the second most common, and sometimes you'll see that's becoming like number one. So it's definitely very common in the world of oncology. And because of that, having a kid with a seizure and brain tumor, it's not uncommon for us. Seeing patients coming to us, we see that, I would say, quite common. And we need to address an idea and, to understand how to define it. Those, like you said very nicely, about this is the acute phase, maybe a couple of seizures versus those that are going to stay with seizures.
Yeah. Wow. These are some kind of scary, very scary statistics. I'm not going to lie. I had no idea that these were this high. So if your child has cancer, the brain cancer is the most common type.
As a solid one, yes, it is.
Yeah. And more second only to leukemia, which I know most of us are familiar with.
Yeah.
Wow.
And most people are not aware of that, which is good. I'm happy when people are not aware of that, but that's what we do.
Yeah.
We will try to touch, a lot of time like acronyms or titles, but in some literature, you'll see it as tumor-related epilepsy or TRE, and some it's going to be late epilepsy associated tumor or LEAT. The acronym does not matter. The idea is we're talking about epilepsy related to brain tumor, either in present or in the past. And now our patient, although have no brain tumor, start to have epilepsy.
Okay.
So it's a nice slide to show a study that basically looked, and do you see my cursor, Monica?
I do. Yes.
Okay. So what we see here is a diagram of a brain parenchyma with a lesion. You see it here. It's a brain tumor, most likely a low grade, that over time grew and expanded. And what they showed is that there is a high correlation with the tumor growing up and the seizure starting to get out of control and getting more and more, along with a patient that was already on 3 medications and basically, and on his, I forgot to say that, I'm sorry, on his targeted therapy, which is oncological treatment for his tumor. And still, because of the tumor is growing, the seizures are kind of like a mark for us that something is not okay with the tumor because the brain is suffering. And the seizures are starting to go up in frequency and sometimes even different kind of seizures when the tumor is really expanding out of its capsule. So there is a very high correlation in terms of the tumor condition, and we'll talk about tumor histology and location. We already mentioned that, and the seizure, I would say, burden.
Or the tumor starts to grow, the more seizures you will likely see. So that's a clue that the tumor is not responding to the chemotherapy. Is that one thing you would say?
I would say not necessarily just chemotherapy. I will take it as a whole, does not respond well to the treatment.
To the treatment altogether. Okay.
Yes. And a lot of time that's a sign for us. For example, if we have a patient that got surgery, got treatment, doing well, and is under surveillance, even getting targeted therapy or chemotherapy, and after a few months, all of a sudden, we have a seizure. Yes, it can be interaction between the chemotherapy and his epilepsy medicine, but for us, it will be, okay, let's get a picture because that can be a sign that the tumor, something is going on with it. The tumor is expanding, the tumor is changing. okay? Now, the main problem for us as physicians taking care of these kids is that we cannot really separate. We cannot separate the brain tumor and the epilepsy. It comes together. And a lot of times, the problem is that over time, these kids are suffering from other problems. They suffer from elevated pressure in their brain. They suffer from brain damage secondary to the surgery, to the tumor, to the radiation therapy. They suffer from neuropsychology problem related to their epilepsy, right? We know that children that have a lot of epilepsy, a lot of breakthrough seizures over time, they have a decline in their abilities. But on top of that, this kid now also have treatment that's not helping his brain in terms of, I would say, the integrity of the brain. Now, chemotherapy helps to control the tumor, even eradicate the tumor, but we know that a lot of times also creates some damage to the surrounding tissue.
Okay.
So the treatment in these patients, especially those what we call the long-term epilepsy-associated tumors, those that are suffering from epilepsy even years after, a lot of time is more complex for many aspects, not just the anatomy of the brain or just the specific tumor. There are different kind of reasons for this patient to be more complex to treat.
All right.
Now, that's a very busy slide. We're not going to get into the pictures, but what I want to just mention that very briefly is what I, bolded here. Is there a connection between the brain tumor itself and creating seizures? The answer is yes. In the past, there was a notion that maybe not so much, maybe it's just the mass effect, so you'll remove the mass effect and it's gone. Not exactly. We know it's changing the chemistry and the integrity of the cells around it, and sometimes even distant from it, which...
So I know mass effect means, sorry to interrupt you. Mass effect means there's something in there, a mass, the tumor, that is pushing on other parts of the brain. And the theory at that time was that's what's causing the seizures. But you're saying now, the research community knows that it's not just the mass effect of the tumor being in there, it's actually the tumor is actually changing the brain altogether.
Correct. And what we call, here I marked it here, a direct cell to cell, some kind of connection or interaction. Now, it's not happening in all of the brain. There are specific really bad tumors that will change it throughout the brain, but most of the tumors are more focal and will create a change around, I would say, the tumor area or the peritumoral brain. Again, this word parenchyma. But it's not just the mass effect, which leads to the fact that if we are aiming our treatment only by reducing the mass effect or taking the tumor out, a lot of times that's not really changing enough for the epilepsy.
Because the cells outside of the tumor have also been affected by the tumor.
Correct.
Okay.
Now, there are specific tumors that know to do that more than others, unfortunately. And some families maybe will recognize the names. The names by themselves, I don't think it really matters much, but I will just mention that because some of them are really common in discussion. One of them is DNET, D-N-E-T, or ganglioglioma, or in general, low-grade tumors or low-grade glioma. Those are really tends to be, I would say, the hot players, so-called, in pediatric brain tumors in relation to create the tendency to have seizures. In adult, we know other features, but we are now focusing on pediatric population. So we know, for example, that patients with DNET, D-N-E-T, it's almost all of them will have seizures at some point. And a lot of them will develop epilepsy as well if this tumor is not amenable for a complete resection, and even that not enough in some of the cases. About a few years ago, the World Health Organization, the WHO, which gave us the classification for brain tumors, actually acknowledged this fact and start gathering them under this umbrella of what we call a glioneural tumors. Again, it's not the name itself, the term is not important, it's a term in Latin. It's the idea that we now start to understand that some of these tumors do create some kind of a change to their surrounding that affecting the brain more than just the tumor itself. Okay?
So again, like your previous slide, there's now even more evidence to show it's not just the tumor that's affecting the brain. The tumor is affecting other parts of the brain outside of the tumor. That's a tough concept to understand.
Yes, and I think that, in some communities it's still debatable, but we definitely see that, and I'll try to show some examples afterwards down our discussion today. I would mention one thing for the parents: if what the patient have is just a seizure. I'm saying just, although I really don't like this word, specifically me, but it's just a seizure. We don't have any other deficit. We don't have any other complaints. That's in a way a lot of times a good thing. It means that the damage to the brain around it is a lot of times not that extensive, and which makes it easier to treat in some of the cases. Okay, and that's going to be the last time I will say just a seizure.
Okay. We know that here, unfortunately.
Yeah. And so I said that before, since so I'll fly on that relatively quick. The aggressiveness of the tumor does not correlate with the tendency to develop epilepsy, especially in pediatric population, but not just. So the fact that the patient have epilepsy does not mean he has a really bad aggressive brain tumors. A lot of times it's actually the opposite. Okay.
So the tumors that are not so aggressive tend to generate more seizures than the ones that are known as aggressive or fast-growing tumors. Is that what you would say?
As a rule of thumb, yes.
Okay.
And some of it related to the fact that unfortunately aggressive tumors tend to just so-called eat the brain.
Yeah.
That makes sense. While the more low grade are starting as a mass effect, pushing the brain, and a little bit by little start to invade the brain and change the brain around them, which most likely create the more tendency to have seizures.
All right.
Now, if we look on the outcome, I try to make it as simple as I can, and I'm not a big artist, so bear with me. So yes, if we talk about, let's start with the tumor. No residual tumor versus residual tumor. So of course, we don't want any residual tumor. That will be the best case scenario for us. And if we can, the best case scenario will be to have no residual tumor, to have seizure-free, no deficit, everything is fine, right? We don't want anything. Less, I would say, something that we want, we'll be okay with it, but not really happy with it, will be we don't have a tumor, but our patient is still with some kind of seizures or even epilepsy. And if worse than that, he has epilepsy and he also now have a deficit after after the surgery, for example.
From taking the tumor out. Yeah. Just to clarify, residual tumor means tumor that's left over. So no residual tumor means you've taken the whole tumor out successfully.
Yes, and thank you for making it clear. I will use the term sometimes gross total resection, or GTR, which means there is no tumor, at least MRI. This is the technology we have. We look on MRI after the surgery and there is nothing. Okay, and sometimes we'll use the term NTR, or near total resection, which means that we almost took it all out, but it's still, there is some residual, there is some tumor left.
Okay.
Now there is the option of residual tumor. So residual tumor, but you make your patient seizure free. So, and a lot of times that's going to be our scenario, because we will understand that we cannot take the whole tumor out because, for example, it's involved, and I will use a hard word, eloquent area, which means an area in the brain that has a high function or important function. You cannot take it out because you'll create a very bad deficit. But you were able to understand the epilepsy and the network in a way that although you left some residual behind, you disrupted the epilepsy to extent, to exact point that there is no epilepsy anymore. There are no seizures. And that's exactly what I want to emphasize today, because this is feasible nowadays. You can leave some behind and still treat the epilepsy. And for some of those low-grade tumors, that's important because some of them, if you look on their biology or their tendency to grow over the years, that can be really slow. Some of them will grow over 10, 20 years. And by then we might going to have different kind of treatment for them. But if we are able to differentiate now and treat the epilepsy right now, our patient will have a high quality of life. And yes, surveillance for their tumor, but their quality of life will be in a different location.
Much improved because no seizures.
Correct.
Yeah. Okay.
Now, the really bad outcome, I would say, from all this graph or all these slides, sorry, will be we have a residual tumor, our patients still have seizures, and we created the deficit. We really don't want to go down this road.
No. Yeah.
Now, back in 2023, on our SNO, we call it SNO, it's the Society of Neuro-Oncology. It was a paper basically tried to give some kind of ideas or guidelines, but it's not focused on pediatric. It's a mixed population, so we always need to read it very carefully because pediatric brain tumors are different from adult brain tumors. And basically, they just mentioned the same thing that we are seeing, and some of them I mentioned before. Lower tumors or lower grade tumors have a higher tendency to create epilepsy. Tumors that have IDH mutants, for if we have families that their kid have this specific mutant on the line, they will know what I'm talking about. Others, it's really not important because we have a lot of different kind of mutation. Those tend to have more seizures. And again, this group of glioneural, which mean DNET, ganglioglioma, those are really, if you hear this word, that usually goes with epilepsy.
Okay.
So for me, I thought about this slide. The numbers are not that important for me. The message is important. First, it's important to understand that a kid that's all of a sudden have a seizure. I'm saying something that is out of the bottom of my heart because I see these patients almost on a weekly basis. A patient that is all of a sudden having a seizure, yes, it can have other reasons, but I would like the physician or even the families to understand it might be something else. The seizure might be a sign for something else. And to consider that and sometimes even demand to have a picture. Just to rule it out.
In any case, not just brain tumors. You're saying as soon as a child has a seizure, you're saying they should have brain imaging.
You should have brain imaging. Doesn't have to be immediate in the middle of the night, but soon enough, not 2-3 years after. Especially those that it's not like one-time seizure after a fever and went away, the patient is not on treatment, nothing happened, everything is fine.
Yeah.
Nowadays, in most communities, I'm saying that carefully because it's not in all, but in most communities, we can have access to brain image. Not, again, doesn't have to be in the middle of the night, but at some point soon after. And then it's important, and this is more for the physician, is sometimes it's worse to get the wrong type of imaging, saying that everything is fine, and send the families away by saying, all it's good, than not having an image at all. So
Yes.
nowadays, yes, it is important to get an actual MRI that is done in a place that knows to read them and to differentiate and making sure there is nothing subtle, because a lot of times those low-grade tumors, especially in the very young population, some people will miss a brain tumor.
Yeah. We see this a lot in the world of focal cortical dysplasia, is kids having imaging at an inexperienced facility with a neuroradiologist that doesn't have the expertise. And so they'll say, everything looks good. And then they'll go to a more experienced team that says, look right there, what we see. So this would mean a 3T MRI at an experienced pediatric facility.
I would say, I will switch and will say experienced pediatric facility, both for oncology and epilepsy, with most likely a 3D MRI. And the reason I'm saying that, because a 3D MRI, as you know, can be in a facility that is not dedicated enough, and unfortunately can give the same idea of, and I will use this population as 6 months old, when the brain is still growing up, and there are differences in the maturation of the gray matter, which is the shell of the brain, and the white matter, that people miss tumors or miss congenital malformations.
Yes.
So I would say experienced facilities, yes, usually those facilities will have a 3D MRI, or at least a very new and upgraded 1.5 T MRI.
All right.
So the factors that will affect the outcome, and by outcome, I mean both. Outcome is both the oncology outcome and epilepsy outcome will be, number one, extent of resection. Still, for most brain tumors with epilepsy, extent of resection is still number one importance in terms of controlling both. You don't always can get a full extent of resection, which means you took the whole tumor out. But you try to achieve that. You try to go down this path. Now, studies in the past, for example, showed that right temporal lobe, which is around here, right temporal lobe lesions or tumors, had a tendency to have a better seizure control. And the reason behind it, when you really read between the lines, is because for most people, the right temporal lobe is the non-dominant hemisphere, which means our language is not on that side, which allowed the surgeon to be a little bit more radical in the resection, which again emphasized the idea that if we can get a much better resection, the likelihood to control both entities is much higher.
The more you can get out, the better.
In most cases, yes, but we're going to have a caveat for that. Very soon we'll talk about it. So this is basically the same idea, so I'll skip that, basically saying different kind of studies, emphasizing again the importance of getting a better extent of resection, which emphasize again the idea of going to a dedicated centers that have experience with doing so. A very recent meta-analysis from 2023 specifically look on pediatric, and whenever we have those, we really hog on to them because we don't have a lot of dedicated literature for pediatric, and this one was one of them.
A meta-analysis, for our families who are unfamiliar with the term, a meta-analysis, isn't that getting a lot of published research papers and analyzing what they all say instead of just one? Correct?
Yes, and
Okay.
it has its own problem. It's not a perfect way to learn about a topic, but it's a very, I would say, convenient way to summarize all the known literature. Now, yes, it means that if the literature had some kind of problems within it, sometimes you miss it. But since you talk about big numbers, for example, this study, they started with almost like 700 patients, and then they narrowed those down. So it still gives us a good idea about a topic. And this topic was specifically what is going on with postoperative seizure outcome in pediatric patients with brain tumors. And what they did nicely, which I liked, is that they differentiate those that went down the path of resection, which means taking the brain tumor out, or the epilepsy focus out, versus LIT, which is a laser ablation for the same reason. And what they found is that at the end of the day, and that's a high number, about 80% of the patients achieved seizure freedom. Now look at the focus. We're not necessarily talking about gross total resection of the tumor, but seizure freedom.
Yeah.
When you try to achieve gross total resection, when your intention is to go down this path. But another one, even more important one, is then when your intention to treat, which means that this is what you try to achieve, is a maximal safe resection. You try to go down the path of removing everything out in a safe manner. The likelihood not just to improve the tumor control, but in general to improve epilepsy is very high, is close to 90%. So there is no question that this should be our goal at the end. And we have discussion about it with our patients, and we have many patients coming to us at St. Jude and at Bonheur as second or third opinion, that sometimes you need to do it in more than one surgery because the tumor is too complex, because you cannot achieve everything in just one try, and you need to do it in several steps.
Yeah.
But the idea, the goal is to try to take as much as you can maximally out, and then to affect both ends, the tumor and the epilepsy.
That's a tough journey for families to think about multiple surgeries, but if it's
Correct.
going to give you a better result, then it's absolutely something they should consider.
I agree. And this is something we don't take lightly. You know,
Mhm.
of course, there is no question about it. If something can be done in one surgery, anyone will prefer that, surgeons included.
Mhm.
But if we see that it's not safe, we'll be as frank as possible with the family, saying it's better to take it in stage, you know, step by step. And I'm not talking about 10 surgeries. I'm talking about usually it's about instead of 1, 2 or 3 surgeries. It's better to do it in steps rather than to just try to get it all done in one step. Sometimes that's a safer way to do it.
How long would you typically wait in between surgeries?
Oh, that's a very, very good question. It really depends on the location and the patient.
Mhm.
For very young patients that need more time to recover, because you know when you're a baby, um, your body needs to recover. You know, we have blood loss in surgery, so sometimes your body needs to a little more, you know, time to get back to its normal self. So we give them more time. And by more time, it's usually several weeks. For more adult patient or, you know, teenagers, sometimes you can do it one on a specific week and the second one on the week after.
Oh, so
So
closer to.
basically you can do that on the same admission. You just give them some time to recover. But it really depends. You really need to tailor that for the patient. So we always in epilepsy have this option, right? To use treatment, meaning medicine versus surgery, or a combination in many, many cases. And these debates will always stay there. And it needs to be out there. It doesn't mean that surgery is the sole treatment for patients with brain tumor and epilepsy. It's not. But in many cases, it should be the forte. It should be the dominant treatment out there. And the medicine is I would say, an accessory or a complementary way to treat the epilepsy, and not vice versa.
Okay.
So, we said that the most effective treatment for this combination is surgery, and the most effective treatment is to try to do a maximal safe resection, aiming for taking the whole thing out, gross total resection. Yet, and that's the big yet. And this is a very scary number if you look on what I just added to the bottom of the screen.
Yeah.
On a study from 2020 showed that about 20% of the long-term epilepsy related to brain tumor and 40% of the low-grade tumors in general, although they took the whole tumor out, they still suffer from epilepsy. That's a high number. And this is basic.
Are these pediatric numbers?
Pediatric numbers.
Mm.
And this basically means that yes, we are aiming for gross total resection, but that cannot be robotic. It has to, take into consideration, taking the patient into consideration, the specific tumor, the location, how much time it's been since the seizures actually started. It's a big difference for me if a patient came to me with 2 weeks of seizures versus those that have 2 years of seizures and just recently someone decided to send them for MRI. It's a big difference. And just, very quickly, I would say those that are with seizures for a long time, I am very concerned that some structures on the brain or even around the tumor are now becoming an actual, almost like an epilepsy generator, what we call epileptogenic, by
Yeah.
themselves beside the tumor. And if you just take the tumor out, that's good for the tumor, but the epilepsy will stay. And I'll show you some example later on.
I think that's because we know seizures can teach the brain how to seize in other parts. Isn't that right?
Yes, completely. And some structures in the brain, such as the hippocampus, are much more susceptible to become injured by an ongoing seizures that are not controlled,
Mhm.
and then becoming themselves a generator for seizures.
Right.
So, yes, taking more is the rule of thumb, but not enough. We'll get to that again in a few minutes. So many patients or families ask about prophylaxis, right? So, for example, the kid or my kid had a brain tumor. We go in for surgery. Should he stay on medicine for seizures? Well, it depends. If the patient, the child had a seizure before, if it's just one seizure, the answer is usually no, because that's not epilepsy really. And if we are able to treat the tumor correctly with surgery and the whole tumor is out, CHOP, Children's Hospital of Philadelphia, showed back in 2011 already that you don't really need to. But if the patient definitely had seizures for many years or they are very young, those should be considered to have preventable or prophylactic treatment over time with very slow, controlled decrease in the dose and even in the actual medicine to take it out. So it's, again, it's not mathematic. It's not that every patient that had surgery for brain tumor should have treatment for epilepsy. Depends.
So you're saying generally, because we know there are never black and white rules in this world of ours, especially with epilepsy, that the younger the child after the brain tumor resection, even if they haven't had seizures after the tumor resection, they should be on medication just in case they develop epilepsy.
I would say they should be considered to get medication.
You
Or
should talk about it with the doctor, with the
correct,
neurologist after surgery. Even
correct. Or at least the family should be advised that this is a risk and they need to be aware of that.
okay.
And yes, it is more common in the very young population of the infants, less than 2 years, less than 3 years, rather than 10 years old.
Mhm.
I want the patients or the parents to understand that if the kid was diagnosed with a brain tumor, had a seizure, or even 2, 3 seizures before surgery, tumor is out. Usually the most centers will keep them under medical treatment for seizures, hopefully just one medicine, nothing more, but we'll try to wean it off very quickly.
Mhm.
Some centers, if it's just one seizure, we are included. If we think we can get the whole tumor out and we don't see injury to the tumor around it, we'll try to let the patient live without and advising the family, be advised, you might gonna have seizures. If you see anything, come back. Most of them will never have seizures.
Okay.
What I don't want to have is a kid that had just one seizure, had a very successful brain surgery, and 2 years after he's still taking his seizure medicine without any reason.
Because we know those can have side effects.
Correct. And
Medication.
it's very nice that you see that, because you say that, because here is the bottom of this slide, exactly that. So why not to give it? Because a lot of them will develop side effects and
Yeah.
adverse effect, especially, by the way, if they are taking now chemotherapy, if they are taking other kind of treatment or going through other kind of treatment, those medication, the seizure medications, they do have adverse effect.
They do.
So we take that very seriously, who we put on prophylactic, who we don't. It's not just, okay, just take it for 1 year, it'll be okay. No, it has to be with a reason.
Yeah.
So we talked about it very briefly before. That's a work that basically looked on this particular population, had surgery, had treatment, not just surgery, did very well, no seizures, no treatment, all of a sudden seizures. And then you need to start thinking about, okay, what happened? First, what you do, you send the patient for imaging. You rule out tumor that's coming back. You rule out that maybe in the first MRI, someone read it as a clean MRI, but there was a very tiny residual that now is growing up. You rule that out. You, of course, rule out any kind of infection or injury to the brain, for example, after radiation, such as radiation necrosis, which is not a tumor, but it's an actual, I would say, inflammation of an area in the brain that is dying from the effect of radiation. You rule those out. And then you can look on other reasons. We know that patients that are taking epilepsy medicine or took, and now they're taking, for example, treatment such as oncological treatment, can have changes in their sodium, which is the salt in our blood. And that can push them into having seizures. So in a way, it's allowed, people with what we call hyponatremia, with low level of sodium in our blood or low level of salt, for some people that will push them for seizures. But having an imaging that rules out the more common reason, which is the tumor is coming back, is very important.
So if you start to see seizures after the brain surgery for the tumor, you really need to get in and get imaging right away.
Yes, you do. Now, we'll define that again for those that are, it's a late onset. If our patient had seizures before, had successful surgery, and have seizures after the surgery, that's sometimes part of the now controlling the epilepsy. And we'll try to control it with medicine. And if we can, then we need to address it as an epilepsy problem, more than just oncological problem. Those that are late onset, this population that had brain tumor, had a resection or treatment, seizure freedom, treatment freedom, or I would call it even not seizure freedom in terms of no medicine, but just everything is controlled, and all of a sudden start to become intractable or having breakthrough, here we really need to be careful. Now, a study that looked on this particular population showed already a long time ago, around 2003, that there are some risk factors for them. And a lot of time we see that, I can tell you from my practice, 2, 3 years, even 5 years after. So we have a specific clinic for follow-up for those that recovered from brain surgery, and it's just follow-up, just imaging, no treatment, nothing. And 2, 3 years after, 5 years after, all of a sudden seizures. And you scan and there is no tumor, the tumor is gone. But now they have epilepsy.
But the brain network is starting to have seizures.
Correct.
And it looks like even 6.5% have their first seizure after brain tumor surgery, more than 5 years after that surgery. That's a big number.
Yep. And it's important because the brain will have changes over time from everything that he's been through. And yes, one of the more significant risk factors is having radiation therapy. Now, nowadays with the new protocols, it's better. Seems to be a better deal in terms of what we see, the effect of radiation on the brain, but it's definitely there.
Yeah.
So before we'll continue, I will say having seizure more than 1 year before the surgery for the tumor and the epilepsy, having just partial resection, not the whole tumor was taken out. There is a residual. Having radiation therapy, having a patient that had some kind of a successful lesionectomy, which means we took the whole tumor out, but still have seizures, although everything is clean, or are very young age. Those are all risk factors to go down the path of a really poor seizure control or intractable epilepsy. And this is the population we really need to address in a different way. So the idea of performing lesionectomy, or again, I'm using different terms, I'm sorry. So complete tumor resection is very important. We don't say it's not, but it needs to take into consideration for the specific patient. Even in a study that was done at St. Jude, we basically saw that there are those that will have or will develop uncontrolled seizure later on. Hence, those patients needs to stay under surveillance. And eventually those numbers can be very high. So we're not talking about 2% or 1%. We're sometimes talking about 25 or even close to 40% that can develop late onset seizures. That's a very high number.
So these kids should be followed many years, even if they're cancer-free, the tumor's been taken out. Are you saying they should keep going back for regular checkups by the neurologist?
Yes.
Parents should be told, keep an eye
Yes.
out for seizure activity,
It's
which we
very
all know
hard to say completely. And it's very hard to say nowadays, even for the very, again, I don't like this term benign brain tumors, but almost benign brain tumors. Oh, it's all out. So you're good, you're cured, no need for follow-up. We don't believe that anymore.
you have to keep an eye.
You have to keep an eye open. You have to tell the families that although it's still rare, it's not common, but to be aware of the fact that it can happen.
Yeah.
So if that's the case, we need to approach those patients, the late onset, in a way that we just don't just address the tumor, we address the whole picture of the epilepsy, including everything that involves, which means phase 2. What is phase 2? Phase 2 is when many families are aware of coming to the hospital for phase 1, which means the kid is connected to EEG, have all the stickers on their head, and having MRI and having all the evaluation. That's phase 1. Phase 2 is very, very similar in a way, but it's more invasive. Now we're going to have electrodes going into the brain, or a grid that sits on the brain itself. It's actually surgery. But the idea of phase 2 is monitoring. We didn't treat anything. I like to call it, we try to get boots on the ground. We want to get the information from the brain itself, not from the skin. And phase 3 will be the actual treatment, resection, laser ablation, neurostimulation, something that will address the epilepsy, and maybe the residual tumor at the same time. Some families ask about, do we use intraoperative EEG? So we use it. I can tell you that it's not something that is widely acceptable because there's a lot of problem with it. But in experience centers, there is good experience with using it as something that comes as part of a full picture. I would not get my decision about resecting more, resecting less, just upon the intraoperative EEG, which means we read the EEG from the brain while we are operating on the brain. It's another tool, but cannot stand alone, cannot be by itself. Go back. So should we do a phase 1 and 2, which mean a complete evaluation for every patient? Answer, as usual, no. We don't need to do it for every patient, but for specific patient, I would really advocate for it. Patient that their tumor is in a very epileptogenic or epilepsy generating region in the brain, such as the temporal lobe, I would urge to at least think about having a phase 1, especially if it's not just one seizure, like, a patient that is now with seizure for a while. But for us specifically, where, we work, anyone that is a long-standing seizures or long-term epilepsy after the tumor got controlled or partially controlled, all of them will get a full workup because we don't believe the pictures anymore. That's the basic idea. So it was shown that doing a supramaximal resection, if we can, even use this term, which means that you take the tumor and a little bit around it, which is a term that usually in the brain, we don't act like this because everything is important in the brain. You don't just take boundaries.
Yeah.
But let's say, can you just do that and that will make the patient seizure free? Usually the answer is no. okay?
You would think it would be the opposite, that it would be, if you take out a little more than the tumor, then you'll also get the area causing the seizures, but
So
that's not the case.
in many cases, that's not the case. And it's better to consider, if you think about doing something like this, to monitor the patient before even doing invasive monitoring and get an idea, but should you do that? Should you extend your resection to a specific location where you don't see a tumor there? For example, the numbers are something we discussed. I just want to show the pictures. This is a case that we did, one of the patients that we treated last year. Let me try to stop it here, okay? So this patient, we're looking on the brain. The eyes are up here.
Mhm.
This is the big brain, that's the brain stem. The tumor is here. And on MRI, on CT scan, everything is flipped. So believe me when I'm saying that this is actually the right side, not the left side. So the tumor is here. It's a little bit hard to see on my screen, so I guess it's for you as well, but it's not taking the whole area, just part of it. So the idea to begin with was just to consider resection of the tumor itself. But this patient specifically had seizures about 2 years before coming to us, to exact 1.5 years before. Late diagnosis, actually, because he was sent for having MRI after a while. And so we put some depth electrodes. You see those tiny, tiny lines? This is
Mhm.
basically an MRI with electrodes in the brain. And what we found out is that the extent of resection has to go much back in order to include an actual area that is related to his seizures. So this one did need a supramaximal resection, but that was tailored according to the electrodes before surgery and some intraoperative monitoring that we did while in surgery. We have now close to 9 months of follow-up and so far no seizures.
Oh, that's
So
great.
I still call it short-term follow-up, but it's a good start.
Yes.
Got an idea of tailoring that to a patient, taking into consideration, yes, you can take the patient for surgery, taking the tumor out and then see, that's an option. But in those that have seizures already for a while, it's better to think about what happened to the brain along this time and how the brain got changed, maybe around the seizure, the tumor, or close to it, and maybe that needs to be included in your resection. So a lot of parents see this picture and say, oh, so everything, what, it's like, I'm going to exaggerate a little bit, but opening the whole brain? The answer is no. We really try to do everything small nowadays, if we can. So we use depth electrode, which is really, really tiny. It's a 1.2 millimeter electrode in diameter. So we don't really do an opening. It's like almost like a, I would say, almost like a stab incision or a needle incision in order to get the electrode in after drilling a 2.2 millimeter in the skull. So we really try to do everything as small as we can. It doesn't mean that smaller is always the better, but I would say that nowadays this is what a lot of us try to achieve if we can. So if the parents are concerned about now taking their kids through something that will be a really big surgery, complex surgery, I would say go and talk to the experience center. Listen what they have to say. You'll be surprised how in many cases we can use a small incision. We can use, for example, what you see here is a tube, which
Mhm.
is can be 12 millimeters, and you can still do a lot of resection with it. Or you can use a laser. So just go and listen if your kid is still with epilepsy after having a brain tumor, rather than to say, I prefer to give him medicine and we're going to live with the epilepsy. There are different solutions nowadays.
Minimally invasive procedures are becoming more and more common, and
Correct.
yeah.
And this is one example. I just like this slide is that we published about the idea of taking a tumor in a very epileptogenic zone that's called the amygdala by creating a corridor or an opening that was the size of a quarter of a coin, basically. So And it's not just us, that's something that is being done, like you said, more and more today, and allow a much faster recovery for the patients. Now, what do we do when we can't take it all out? When we can't really take a lot of the tumor out, or we took a lot of it out, but the epilepsy is coming from an area that we cannot resect. Because this area, for example, is the area that is the motor function, which moves the opposite side of the body or related to our language. Then we're talking about the option of creating a neuromodulation or neurostimulation. And there are three main devices nowadays. One is the vagal nerve stimulator, which we put in the neck, the DBS or RNS. Both of them are different kind of companies, but the idea is the same idea of stimulating deep portion or surface portion in the brain. That in the DBS system, it's connected to a battery in the chest. In the RNS, it's a battery that sits within the skull. And all of those, I would say, are complementary and very important to treat this patient that you cannot really give them more epilepsy surgery solution because it's an important area of their brain. And I can give you an example. I don't have the slides on her, but a very nice lady that we help, a young teenager going to college, the brain tumor that was missed, by the way, because again, those very low grade was on the bottom of her brain and was read for many years, which maybe should have been addressed as well as a cortical dysplasia, as a congenital malformation. And she had episode that someone think maybe it's a seizure, maybe it's not, until she really started to have seizures. And then it was obvious that what she has is actually low-grade tumor at the bottom, close to her skull base. The problem is that it was residing in a location that's actually related to her language as well. So her surgery included a combination of all of the above. She had monitoring with electrodes to define exactly where the seizures are coming from, disconnecting the tumor from this area, so the tumor was resected. And then for the area that we could not resect, she got RNS.
Responsive neurostimulation, the one that goes in the skull.
Correct. This one here on the bottom. Yeah. And she's now close to 2 years already, seizure-free. She is already in college, and she has a very high quality of life. So that's the idea. Now, yes, we all tend to give, good example, but there are a lot of good examples. That's reality. But you really need to tailor the treatment for each patient.
So I know that the RNS device is technically not approved for use in pediatrics right now, but a lot of surgeons are using it off-label and more hospitals are starting to have it. So for those devices, especially DBS and RNS, VNS is widely available for children. You should go to a hospital that has those devices and a team that has experience implanting them.
Completely. And that's a very, very important statement, because the device is one thing, but what is being done with the device afterwards, which means the neurologist taking care of the patients has to know what to do with them, because otherwise there is no point. Almost there is no point. For example, for the RNS, the whole idea is that the RNS give a feedback of the EEG, and the neurologist, the epileptologist, needs to change the setting accordingly. So if they don't know how to deal with it, that's a problem.
Yeah. So they have to have the right experience, and then they have to have access to the device in the first place. They have to be able to get it there.
Correct. And yes, it is not FDA approved yet, but we are getting more and more approval as we go. Sometimes we need to go case by case. But I think that in a lot of places, the general idea is that, yes, it can help. So for specific patients, we can help them, and we get more and more approvals. What about treatment that is not just surgical? Surgery is not the only way to treat cancer. What about radiation therapy? What about chemotherapy, or even targeted therapy, which is kind of chemotherapy that is more advanced? Those are known to help with seizures. Not the same as surgery, but can definitely help, especially radiation, especially focal radiation. And that can be a solution for those areas, for example, that you cannot resect, you cannot treat, and you don't want to put a neurostimulator there because you still treat it as an oncological disease. So the focal radiation can definitely help with that. Targeted therapy, I just want to mention that maybe some families are aware of this term, mTOR inhibitors.
Yes.
We know that more on the patient that suffer from a condition that's called tuberous sclerosis, but not just. It's now been used more and more in other entities and showing very nice results. Again, if you ask me, is that a solution to replace surgery? I would say I wish, but not yet. Okay. So at the end of the day, we still are in 2024 in a position that for most of those tumors, the first treatment should be surgery. So looking for the future has a lot of, in my mind, a lot of promising ends, because we know more and more about the entities or the sub-entities of the tumors, or what we call the molecular subtyping or genetical subtyping of the tumors, which allows us to really tailor targeted therapy. Now, if the targeted therapy is treating the tumor, in a lot of times, it will treat the epilepsy at the same time. Now, for some tumors, it's better. For some, it's not there yet, but it's something that is happening right now. And we see that with some entities such as BRAF mutation, which is specific mutation in low grade, that yes, those tends to be more associated with seizures on the one end, but those now have targeted therapy to treat the tumor. So we'll see what the next few years will bring to us. So the last questions that I want to answer is, before we'll give you some examples, is when can we stop the medications? Okay, we had the surgery. We had a successful surgery for the tumor, for the epilepsy. Can we stop the treatment for the epilepsy right away? The answer is, in most of the cases, no. Again, if it's a one-time seizure before the diagnosis of the tumor, that's a different kind of discussion. But for those that really had epilepsy before, having surgery for the tumor, removal of the tumor, even a very successful one, does not mean stop the seizure medicine. We don't know how the brain will respond yet. So for most of them, the minimum will be around the 6 months of follow-up. Most will wait for about a year before they will start playing, so-called, with the dosage, with the number of medication and such. But the idea at the end, all of us will want to see our patient seizure-free and without medications. But it has to be gradual. So, if we still have time, Monica, I can go through a few quick examples.
Yeah, let me stop for a second. A moment. Okay.
So I'll go quick through several examples, of course, without any identification of the patient themselves, just to give some idea about this combination. So I'll start, I would say, with the more classic, simple, non-epilepsy, more seizure-related problem. This is a 14 years old, at a presentation that triggered MRI, start to have seizures and some headaches. And again, we're going to look on MRI that the nose is up here, the back of the head is up here, this is right and this is left. And what we will see, and I will stop when it's going to be closed, we see something here that definitely does not look like it's supposed to be there. And that's a brain tumor.
Wow.
Very angry brain tumor. So what is the main problem for this particular patient? That's his left hemisphere. And for most of us, about 85-90% of us, this is going to be the hemisphere where the language is going to reside, which we'll call the dominant hemisphere. And hence, yeah, we knew that the tumor needs to come out. The question was, how aggressive can we be on the edges, because that's where we actually see brain, and that might be where he has language. So for us, I know I'm biased because we do have this ability at Bonheur to do this kind of workup relatively quick. We have everything in-house. So it allows us to basically send the patient for workup that for us includes a TMS, which is a transmagnetic stimulation, which is a way that the patient is awake and following answering specific questions and following specific commands like lifting your arms and such, and give me a map of the function, including the motor function and the language function. Our team, I'm blessed with that, is very, very experienced. So, we have a very high correlation between that to an actual fMRI, which is a functional MRI that can give function of the brain. So we use the TMS very commonly, along with another tool that called MEG, which is a very fancy way to say magnetoencephalography, which is a way to combine the magnet or the anatomy of the brain with the function / possible interictal activity, which means the electrical activity between the seizures. Try to follow an area of the brain that is not normal from electricity perspective. It doesn't mean that the seizures are specifically coming from that area, but in the vicinity. And that's what we did. And what we saw is basically that very nicely, it's a small picture, but I think you can see it. It's coming from the tumor.
Those yellow dots, that's the MEG,
Yellow
right?
dots. Yes, that's the MEG. Yeah.
Someone once told me a MEG is like an EEG on steroids with magnets.
That in a way it is.
Really turn it up with the magnets.
Yeah. And and even that, it's very, very important who is your team, because it's not the MEG itself that gives you the analysis, it's the person that treats the MEG. So we got the map that we wanted, and we saw that you saw the red dot. That's where some of his language function was. So we see the vicinity of how important it is to know this kind of stuff. This patient went for a successful resection, a complete resection. Unfortunately, he had a bad tumor, but in terms of the epilepsy, we have already with him close to 2 years of follow-up. He has no seizures.
Oh, that's so great.
We had a pre-op seizures, not epilepsy, a very distinct tumor, a quick workup that allows to be more safe and understand his relationship to the brain, complete resection. We stopped the seizure medicine very quickly after, and that's it. So that's one example. That's, I would say, the more simple example in terms of the combination of the two.
That's great.
Now, we'll start to move into something more complex. 6 years old, had this embryonoplastic tumor, or the DNET, the one that we said that is very, very likely to create seizures or epilepsy. And a very complex tumor, not a very easy one. You'll see the pictures, and it had a partial resection somewhere else, which left a lot of residual and left a very bad epilepsy as well. And his epilepsy progressed to the point that he started to have problem with his cognitive function started to be delayed. He started to have fall attacks. And here's some pictures. And it's the same kind of overview. So again, this is right side, not left side. And everything that is dark is actually tumor. And it's a big tumor. And we see this very dark area, that's the partial resection. So it's not like they did nothing, but there's still a lot left behind. Why is left behind?
Oh, he had already gone somewhere for a prior surgery? Oh,
Correct.
I didn't catch that before. Okay.
And the main problem is that this tumor is invading very important areas. Invades the area that control the motor function. It invades area, what we call basal ganglia, which are deep structures in the brain that control fine movements. He engulf, you see this tube here, this white, this is a very important blood vessel that, any kind of injury can create a really bad stroke. So there are a lot of reasons to say that's a very dangerous thing to do. And when we met with the family, we said, yes, that the very simple answer, we cannot take the whole tumor out. Because taking this whole tumor out, it's almost like doing a hemispherectomy. And the kid does not really need hemispherectomy. Now, you can debate about what I just said, but his hand was still functionable. He's old. He's 6 years old. Was about to become 7. And the main thing was to see if we can, go through that without going deep. And for me, there was something else. Anyone that know what, when I'm saying the word hemispherectomy, I'm talking about the disconnection of half hemisphere. When we do so nowadays, we leave the inner part of the brain, the thalamus, we leave that intact, because we know from previous works that taking a real resection of a full half hemisphere has a lot of ramification. So we don't do that anymore. But what we see here, that the tumor actually sits in the very inner part of the brain. So taking half of the brain out will not really solve the problem. So we try to look at it in a different way. And in a way that we said, now I'll skip those films, I'm sorry on that. So we have 2 problems. We have a tumor, we understand we cannot take the whole tumor out on the one hand. On the other hand, we know that from the pathology, this tumor tends to really stay the same for a long, long time. But we have a really bad epilepsy. And as such, we started to say, okay, let's look at it in a different way. We will take as much as we can from the tumor, but I want to know which part I want to take that will involve the epilepsy network. Hence, the patient went through quite a bit of workup. And this workup included some workup that he had in his previous place. So we always use the data that came from the previous place. We don't disregard it. Everything that was done is important. And he had some workup that included some SEEG or depth electrodes. We talked about it before. The workup from those depth electrodes showed something very interesting, that a lot of the seizures were not being generated from where the tumor is actually being generated from a structure that has no tumor in it, which is the hippocampus, which is just below it. So again, kid with a long-standing epilepsy, a tumor that was partially treated, and his epilepsy is not completely generated from the tumor itself. The tumor is involved, there is no question about it, but he has other structures that are much more involved in his epilepsy right now. And then we continued, and the conclusion was that, and what I forgot to mention is that we can use those depth electrodes in order to map the function, not just to capture seizures, but also to stimulate and to see which electrode sits in an area that is controlled the motor function, which one controls speech, etc. And we saw that the motor function is away from the epileptogenic zone and not exactly in the area that we want to resect is not exactly involved in motor function. The tumor did go to motor function area, but not the epileptogenic zone itself. And when we looked on the MEG, those little triangles again, we see that it's in a specific, almost like a specific location on the back of the tumor, which makes this area much more important to me as a surgeon than other areas of the tumor. Because my goal now is to take as much as I can from the tumor, but to try to eradicate the seizure at the same time. So taking everything into consideration, including the transmagnetic, the TMS, which showed me the function, the motor function that is here, and the tumor is here, and the epilepsy is here. So it's away. Taking all of that into consideration, led us to conclusion that we can go and take a lot of the tumor out, focusing on the back end of the tumor, including the area of the hippocampus, which was involved. And the patient went for first surgery. So we had a discussion with the family and we explained that because the tumor is being almost like split in the middle by a structure that cannot be touched because all the fibers of the motor fibers are going through it, we'll need to split it for two different surgeries. One that comes from the side and one that will come from the midline.
Okay.
And the patient went for surgery. I believe this is, no, not this, I'm sorry, here. And I'll stop here. And basically, the area of the temporal lobe was resected. A large portion of the lateral portion of the tumor was resected, but we did not touch all the midline. That was not part of what we wanted to achieve. That's it. And he did very well. He had minimal weakness that we knew that will come back because he was monitored throughout the case. And whenever they monitor, the patient is monitored and the function is okay, we know it's going to be okay eventually. And one thing that we really liked is that his seizures almost stopped completely.
Oh, that's wonderful.
The one portion that was left that was happening from time to time was very, very rarely. He used to have almost daily drop attacks.
Oh,
Drop attack is when the patient have a seizure that basically almost like shut down the system, so-called, and you just fall down on the ground. Can be very dangerous. So that led us to the second step, which was to do a corpus callosotomy, which is a surgery to disconnect the middle portion of the brain connecting the two hemispheres, while taking some of the tumor off the middle portion that was amenable for resection. We have now, I think, yeah, we have more than 1 year of follow-up with this patient. He is now no seizures.
oh, that's great.
He has one AED, one anti-seizure medicine that is down completely. He had some left hand weakness that is almost completely back to baseline. So that's what we want to achieve. Will we continue to follow? Will he need more? Maybe he will need more in the future. But for the time being, he made an amazing advance in terms of a kid that had multiple, more than 10 seizures a day to have no seizures at all.
That's so wonderful. I do remind families, we do remind them here to remember, I mean, most of us are unfamiliar with brain structures. Your corpus callosum is one of many connections that go from one side of the brain to others. And I did not know that until I entered this world. So the hemispheres can still communicate,
Right.
not the seizures, but in terms of the drop attacks, other brain functions across the two sides of the brain. So it's just so wonderful that this young man, this young boy did not have significant neurological deficits after the corpus callosotomy.
Yeah.
Wonderful.
And I think this will be, I believe this is the last example I want to give you. And there's a reason it's another DNet, because those are really common in terms of their complexity. And I like to give this example because this particular tumor, as a tumor again, will be a very slow growing tumor. So 14 years old, so definitely not a baby, already had surgery in a different location and already been on chemotherapy for the DNet, which did not work, and came for us for a second opinion. And his tumor again, which is unfortunately common with the DNet, is a complex one that again involve many of the deep structures. We can see it here in areas of the brain that you cannot take everything out, engulfing very important blood vessels. And he has a very bad epilepsy, to the point that his cognitive function for being an A-straight student start to drop very significantly. His family noticed that his memory is going down quite tremendously. Part of it will be secondary to his chemotherapy treatment, not just the epilepsy, but the combination of the two definitely don't help him. So again, taking everything into consideration we discussed about today, in my mind, this kind of case cannot just be addressed by, let's go and take the tumor out. It's way beyond that.
Mhm.
We'll look at it in a different way. We perform a phase 2 evaluation, SEEG. You see the diagram up here with the electrodes going in. And we found again, what I just showed you on the other case, that the structure that had no tumor in it was very involved in the epilepsy. And it's not uncommon that this structure is, again, the hippocampus. And the reason is that the middle portion of the temporal lobe, a lot of time when the tumors are in vicinity, or if the temporal lobe is part of the epilepsy network, this structure will become a generator that is almost like going by its own, creating seizures. Now, if I'm going only after the tumor, then I'm going to miss that. The seizures will stay. So eventually, we decided to go and again to break it 2 stages. For him, because of the location of the tumor, and this is a CT showing the electrodes going in and out. For him, we had to split it not to 2 surgeries, but to 3 surgeries. So first stage, 80 to 85% extensive resection of the tumor, and specifically stop in his seizures almost immediately. But not complete, but almost immediately. And then we continue to the second stage that eventually completed almost a 95% resection of his tumor with a complete resection of the hippocampus and the areas that were involved in the network that we found out because he had a phase 2, and the patient is now, I just seen them recently, has no seizures at all. His function is significantly better in all aspects, in school, in sport, in everything. So that's exactly what we want to achieve. And I'll fly. I'm going to skip this one because I think we can always talk more and more and more.
We could be here all day.
But the
Yeah.
bottom line is that there are solutions for patients that suffer from both brain tumors and epilepsy. There are solutions for those that have seizures and brain tumor. There are solutions for those that have a very complex intractable epilepsy and brain tumors. No kid should live with epilepsy just because it's epilepsy. And no family should get a notion of, we treated the brain tumor, just now find a way to live with the epilepsy. No, we can treat both. And I think this is my message in terms of what we should do. Not everything always works exactly as you want, but we can definitely try to do more.
Thank you so much for taking us on this very deep dive about brain tumors and pediatric epilepsy. We're very grateful for everything you do for the children in our community. Thank you so much, Dr. Shimony.
Thank you very much. Have a blessed day.